Hello everyone, welcome to RAAONLINE. I am Dr. Abinaya. I am a consultant pediatrician. So the discussion now is on portal hypertension. This is based on the Nelson textbook of pediatrics. Yeah, so we'll get started. So the outline of this presentation will include definition, types, etiology of portal hypertension, on history and examination, what are the findings, how will you investigate a case of portal hypertension, and management, both medical and surgical. Finally, a brief slide about tips and its complications. Yeah. So, portal hypertension. So, first coming to the definition. Increased pressure in the portal system is portal hypertension. How much increase? Portal pressure above 10 mm. Some guidelines say it is 12. So, we will keep it as 10 to 12 mm of mercury. Okay. So, in the developing countries like India, the most common cause of portal hypertension is EHPVO, then liver cirrhosis. Okay. Most commonly, very rarely we will get other causes. So, if you are able to find out an EHPVO and differentiate it from cirrhosis, it is more than enough from a general pediatric point of view. Okay. The common presentation of portal hypertension, because of the varices, there will be gastrointestinal bleeding. That is the common clinical presentation. So, one will be, how will you differentiate EHPVO and cirrhosis from a variceal bleeding is, variceal bleeding due to EHPVO will be well tolerated, which means the child is hemodynamically stable although there is a variceal bleeding. But a cirrhotic child, if the child goes for a variceal bleed, the child will be very sick and hemodynamically unstable child. Okay, so remember this point very well. Some of the alternate definitions we will see. So, you can see this alternate definitions here. So, the pressure gradient, one is you absolutely measure the portal vein pressure. The other one is the pressure gradient can be measured between the portal vein and IVC. If the pressure gradient is above 10 to 12, okay, that is also portal hypertension. And more than 10 there will be varices. The pressure gradient of more than 12 will have bleed and ascites. Okay. If it is around 10, it is a subclinical portal hypertension. Or intrasplenic pressure more than 17 or an hepatic vein pressure gradient of more than 4. So, from an exam point of view and even from a clinical point of view, just remember the first one, portal venous pressure definition and this portal vein and IVC pressure gradient. So, few anatomical points. So, the portal vein is formed by the union of splenic vein and superior mesenteric vein. Inferior mesenteric vein already goes and flows inside the, flows and joins in through the splenic vein. Okay. So, the varices means there is an abnormal communication between the systemic and the portal venous circulation. Those are the varices. Okay. So, when does varices develop? When the pressure in the portal venous tract is so high that all the blood from the portal venous tract will get diverted into the systemic circulation. Okay. So, these collaterals or these varices will develop to decompress the portal venous system because the pressure is so high in the portal venous system. So, we will see where all varices can be there. Most common sites 3. Okay, one is, first most common will be lower esophagus, second will be gastric, third will be rectum. Further down in the discussion, I will be showing where else varices can come. Okay, pictures and collaterals and all I will show you. Less common sites are peribiliary, retroperitoneal and in the bare area of the liver. These gastroesophageal varices are the ones which are more prone to bleeding because of their position and because of their constant exposure to food and acid. Sites around the splenorenal or in the retroperitoneal, the bleed is less but they might cause compression symptoms. Okay. So, there are many varices. 3 most common varices you should know: esophageal, gastric and your rectal varices. The other less common sites you should know and which will bleed more, which will cause compression symptoms more. Yes, so site of the collaterals. So many different collaterals have been mentioned here. So, esophageal, this is the paraesophageal site of collaterals. This is gastric, that is retrogastric. This is the coronary, collaterals, gastrorenal, splenic or the splenic collaterals. So the center one, this is the caput medusae, and you can see retroperitoneal, paravertebral, etc. Okay, so these are the various sites of collaterals. So see, almost 12 sites of collaterals are present. So we will see why does portal hypertension develop. Portal hypertension can develop because of the compression anywhere. Either it can be prehepatic, either it can be intrahepatic or posthepatic. Okay, prehepatic means before the portal vein enters the liver. Okay, so per se there can be some abnormality in the portal vein agenesis, portal vein atresia or stenosis, or very commonly portal vein thrombosis. Okay, when there is an umbilical vein catheterization, portal vein thrombosis is common, or a splenic vein thrombosis or an AV fistula. This is the prehepatic one. Intrahepatic means any hepatic pathology which is causing portal hypertension. Okay, so hepatic pathology is, it can be liver cirrhosis or it can be a non-cirrhotic portal fibrosis, congenital hepatic fibrosis, all these are common. Other disorders like non-alcoholic fatty liver disease, your Wilson's, GSD type 4. So any intrahepatic cause of chronic liver disease you can write. Post-hepatic, once it exits the liver, then if there is an obstruction, typical example will be your Budd-Chiari syndrome, that is hepatic vein or the IVC obstruction, or further up, that is the constrictive pericarditis, your IVC is not able to deliver. Okay, constrictive pericarditis or veno-occlusive disease or a general hypercoagulable state. So this is the classification. You first divide as prehepatic, intrahepatic and posthepatic and start writing the causes. The most common cause that we have missed here is biliary atresia. If a child presents to us, a well-thriving child somewhere between 4 to 6 months presenting to you with hugely distended liver, cholestasis, yes, it is biliary atresia. Ask for the color of stools, clinch the diagnosis and treat immediately. Metabolic liver disease, yes, we have mentioned. Autoimmune hepatitis was missed here, so I have mentioned it separately. Okay, so again same thing only, prehepatic, hepatic and posthepatic. Prehepatic means here, okay, any portal vein issues, so atresia, stenosis, thrombosis, splenic vein thrombosis, etc. Intrahepatic, all your chronic liver disease you can write. Post-hepatic, start from Budd-Chiari syndrome, veno-occlusive disease, further in the heart, constrictive pericarditis, right-sided heart failure, etc. So we will discuss in detail on EHPVO first. Okay, because this is the most common. Yes, first most common is EHPVO, second is cirrhosis. So EHPVO is extrahepatic portal vein obstruction. Here there will be a development of portal cavernoma. There will be multiple collaterals which will develop around the portal vein. It is absent, it is in the absence of an associated liver disease. There is no liver involvement. Okay, liver involvement is absent. Portal cavernoma will be present. Okay, so obstruction of the extrahepatic portal vein with or without involvement of the intrahepatic portal veins. Okay, hepatic veins may not be involved, or other segments of the splanchnic venous axis. Your splenic vein might not be involved, mesenteric veins might not be involved. Okay, so this is the definition. This is the most common cause of portal hypertension in Indian children. Why so? How all a portal vein is getting obstructed? There can be multiple thrombosis. Okay, so the common causes we will see: the portal vein, umbilical infection, sepsis, when you do an umbilical vein cannulation, repeated abdominal infections, sepsis, dehydration which will lead to a hypercoagulable states, and abdominal surgery or trauma. So these are the risk factors, or you can call as causes. Okay, less commonly some abnormality in the portal vein. Yes, prothrombotic state also we have mentioned. Fine. What is a portal cavernoma? So portal cavernoma, you see a lot of tortuous vessels around the portal vein that will be seen around the porta hepatis. Okay, so these are the tributaries of the portal vein. Whenever there is a pressure, there is a high pressure state, what happens? All the vessels will become tortuous and then they form a cavernoma around the portal vein. Okay. So, extrahepatic causes are the most common, followed by intrahepatic. So, something which is very similar we have already mentioned. So, clinical features of portal hypertension. First, variceal bleed. Presenting feature is variceal bleed. Following variceal bleed, the child can go for encephalopathy, spontaneous bacterial peritonitis, especially in children with cirrhotic. Your EHPVO child will manage very well. Non-bleeding manifestations, definitely splenomegaly. Okay, whenever there is a portal hypertension, there is splenomegaly. Because of the hypersplenism state or because of the variceal bleed, there will be anemia. Transient ascites will be there in EHPVO, but ascites will be there in a cirrhotic child. Epistaxis and hypersplenism. Okay, so these are the clinical features of portal hypertension. History. So, history again, just we have seen for EHPVO. What are the history suggestive of? What were the risk factors? So, same thing only. And history for chronic liver disease, you should start from the history, maternal history of hepatitis B, C, torch infections, etc. History of drug abuse, mainly for hepatitis B, C and tattooing, etc. History of consanguinity is mainly to rule out any family history of liver disease, Wilson's, PFIC, etc. Recurrent jaundice, high colored urine, pale stools, itching, steatorrhea, for this history also has to be asked. So, examination clues. In EHPVO, liver will be small, splenomegaly will be definitely present, there is no ascites, ascites is absent and you can see the collaterals. If this is the picture, it is EHPVO. What about cirrhosis? Cirrhosis is the liver is firm, right? Splenomegaly is present. Anterior abdominal veins, the collaterals are there. Ascites, mostly it is present. Okay. Any dysmorphic facies? Alagille syndrome, pruritogenic skin marks, thick hyperpigmented skin gives you a clue that it is a cholestatic condition. Firm liver, moderate splenomegaly, it is congenital hepatic fibrosis. Okay. Firm liver, especially the left quadrant, left lobe of the liver. Okay, that is below xiphy sternum. We should think of congenital hepatic fibrosis. And Bucchiari syndrome will have a tender hepatomegaly, ascites, recurrently forming ascites, tense ascites in Bucchiari. Dilated abdominal veins not only in the anterior abdominal wall but also over the back. That is Bucchiari syndrome. What about cardiac cirrhosis? Tender hepatomegaly and you can see the pulsations. JVP will be elevated. What is the baseline investigation? Start from your complete hemogram. There will be anemia that can be due to blood loss or because of impaired absorption of iron due to portal hypertension. Hypersplenism will have two cell line involvement or sometimes even pancytopenia. Liver function test is normal in non-cirrhotic cases of portal hypertension. Of course, liver function test will give you a major clue of cirrhosis, of cholestasis, etc. So, you start with imaging. You first investigate with an ultrasound with Doppler, okay, to know the flow of the vessels. So, in ultrasound, we will be able to see the size of the liver, the surface irregularities of the liver, how is the spleen, is there free fluid, that is there ascites, what is the anatomy of the portal venous system, the collaterals, etc. So, next, splenomegaly, omental thickening, any collaterals, etc. will indicate the chronic portal hypertension. For cirrhosis, increased liver echoes, the liver will be very irregular, splenomegaly, ascites will be present. That is cirrhosis. So, further down, of course, in congenital hepatic fibrosis, there will be presence of renal cyst and cholangitic form of CHF, there will be biliary dilatation. In Bucchiari syndrome, again there will be obstruction where? Obstruction in the hepatic vein outflow tract. IVC obstruction can also be seen. Cardiac cirrhosis, there will be liver echoes altered with dilated hepatic veins. We should confirm it with echo. Okay. Next, moving on to the CECT abdomen and MRI. So, this is a hugely dilated portal vein that you can see here. Okay. CT scan is not routinely indicated because most of the findings we can get from the ultrasound Doppler itself. Okay. But it is required prior to liver transplant and it has the advantage of displaying the varices and any hepatic abnormalities. So MRCP is done when you have a cholestatic condition. Okay, cholangitic type of portal hypertension, etc. For etiology, we have a list of investigations. So most of it we have read in their separate chapters. So for identification, what is the cause? If you know it is a chronic liver disease, you investigate in terms of chronic liver disease based upon the age wise. So in the chapter discussion on chronic liver disease, I have discussed age wise etiology of chronic liver disease, and if the child is in that particular age group, you are going to investigate those. Okay, not going to do everything. So go through the video on chronic liver disease. Yeah. So you do a prothrombotic workup in a portal hypertension, in a pre-hepatic case of portal hypertension. This is for Wilson's disease. Do a serum ceruloplasmin, KF ring, 24-hour urinary copper, D-penicillamine challenge test, etc. Chronic liver disease, of course, rule out your Hep B, Hep C, rule out autoimmune. Yes. And PFIC, if it is a cholestatic condition, pruritus marks everywhere, there is a familial history. Serum bile acids have to be taken. Serum bile acids will be high. GGT levels will be very high. Okay. And next will be do a liver biopsy in cases of autoimmune liver disease, Wilson's disease, etc. Okay. Liver biopsy also, there is a separate video you can go through. Fine. So if a child comes to you, the very first presentation is going to be an acute variceal bleed. So you suspect EHPVO because that is the most common cause. Okay. So first our aim will be to resuscitate the child. Okay, volume resuscitation of the child. So airway, breathing, circulation should be taken care of. Volume, resuscitate the child. Make sure not giving too much of boluses. If the child is in shock, give saline boluses. Otherwise, maintenance IV fluid is fine, because when you're overloading the child with an acute variceal bleed with boluses, in a hemodynamically stable child, what is going to happen? The varices will get filled with the extra saline, extra bolus, and that will help in dislodging the clot. So be very careful. If there is hemodynamic instability, if there is shock, give boluses. Otherwise, maintenance of IV fluid is fine. Start with octreotide bolus and then give octreotide infusion, PPIs, etc. Plan for an emergency endoscopy. So, endoscopy, if there is portal hypertension, we do this endoscopic variceal ligation. If there is no rebleeding, then you initiate the secondary prophylaxis, which I will tell now, and you discharge the child. If there is continued bleeding, you have done the endoscopic ligation, you have done the banding, but still there is bleeding, you do a balloon tamponade. But balloon tamponade should be kept maximum up to 12 hours in the child, not more than that. And then you can plan for a TIPS. Okay. Early rebleeding is that you can do second time, you can do the EVL, or you can attempt a sclerotherapy. Okay. Yeah. So octreotide, the dose will be 1 mics per kg as a slow bolus, followed by 1 to 2 or 1 to 3 mics per kg per hour. Maximum 4 mics per kg per hour can be given for up to 24 to 48 hours. Alternative is sterilely present, we don't use much. Okay. So endoscopic treatment, there are multiple methods. One is sclerotherapy, another one is endoscopic variceal banding or ligation. Sclerotherapy is you inject a sclerosing agent into the varices so that it will shrink. Okay. Multiple sessions will be required for a sclerotherapy. Okay. And this one is the preferred procedure, endoscopic banding or variceal ligation. So your EVL is the preferred procedure. It will cut off the blood flow to the varix, apply a band, silicone band tightly around it, that will cause subsequent thrombosis of the varices. It requires only less sessions when compared to your sclerotherapy and less complications when compared to sclerotherapy, making it the treatment of choice. Yeah, so you can look at the band here, endoscopic variceal banding done. Sclerotherapy is you are injecting. So individually you have to find all the varices and you go into the individual varices and give the sclerosing agent. Okay, this is endoscopic sclerotherapy. This is endoscopic variceal ligation. So there are grading of your esophageal varices when you do the UGI endoscopy. Okay, how is the varices? So from grade 1 to grade 4. Grade 1 will be micro vessels. Grade 1 will be 1 to 2 fine caliber varices, but up to 3 mm diameter. Grade 2 will be 3 to 6 mm diameter. Okay. So grade 4 will be more than 6 mm diameter, and this can be present in any part of the esophagus. Usually they start in the distal esophagus. Okay, grade 1 and 2, it is present only in the distal esophagus. In grade 3, it may reach even to half to one third of the esophagus, right? So this is the UGI grading. See here how tortuous dilated varices are present. Okay, yeah. So I have told about the balloon tamponade here. So balloon tamponade is again an emergency procedure. The Singh taken Blakemore tube or the Minnesota tube. So this is done in children only when there is severe rebleeding in the child. So primary prophylaxis. Primary prophylaxis you start even before the child has a UGI bleed. So you have diagnosed a child with portal hypertension. You do an UGI endoscopy. Okay, you do an UGI endoscopy and you do a variceal ligation. Say it will be grade 1 or grade 2. No, even before the first UGI bleed, it will be very small. So you can do a variceal ligation and you keep doing it for every 2 weeks or at least every 4 weeks. That will cause complete variceal obliteration. Or, along with this, you give propranolol, tablet propranolol 20 mg twice a day. This can be given, but it has to tolerate, the child has to tolerate, measure the heart rate. Okay, so it should not, the child should not go for bradycardia. This is your primary prophylaxis. Secondary prophylaxis is when after the first bleeding has happened. Okay, you are going to continue on propranolol and so block the beta 2 receptors that will cause splanchnic vasoconstriction, because propranolol will cause splanchnic vasoconstriction. That is the mechanism of action. Dose yes, 1 to 2 microgram per kg per day. Adverse drug reaction will be bradycardia. Propranolol will reduce the heart rate. Severe cases they can go for heart failure and bronchospasm. So surgery. Surgery is when there are recurrent variceal bleeds. It is not amenable for endoscopic variceal ligation or your sclerotherapy, then we have to go for surgery. Surgery is going to be your decompressive shunt surgery. You are basically going to create a shunt between the portal and the systemic circulation. So when there is failed endotherapy or there is severe thrombocytopenia or the child has gone for hepatic encephalopathy or hepatopulmonary, you do this decompressive shunt surgery. Splenectomy. Hypersplenism is not an indication. We don't regard this as a possible procedure. Only when there are repeated infections or there is physical discomfort by a massive spleen, only then we do the splenectomy. Okay, so we will talk about the decompressive surgery. Tips: transjugular intrahepatic portosystemic shunt. This is the expansion of TIPS. Okay, so percutaneously we will create a connection within the liver. Within the liver, you create a connection between the portal and the systemic circulation, that is TIPS. So this will definitely reduce the portal pressure in patients with portal hypertension. This is less invasive than a surgical procedure. Okay, so when are you going to do TIPS? If the variceal bleed is not controlled medically, you do TIPS. If there are recurrent refractory variceal bleed, you do TIPS. When there is refractory ascites, we do TIPS, and in Budd-Chiari syndrome, we do. Okay, so TIPS is, it's a percutaneously created, so you enter the hepatic veins through the transjugular route. So basically you can see that this is the shunt which is created. This is the hepatic vein, okay, right and left hepatic veins. So there is a shunt which is placed between the hepatic vein and this is your portal vein. Okay, this is the liver, okay, this is the portal vein, this is the hepatic vein. You basically you put a shunt here. So what are the contraindications? Right-sided heart failure. So when you create a shunt like this, so much of blood is going into your right-sided heart. No, so already if there is a right heart failure, we should not do TIPS. If there is a polycystic liver disease, it is not amenable. So TIPS cannot be done. Severe hepatic failure, again this is a relative contraindication. Okay, fine. So complications of TIPS will be, sometimes the shunt what we have created, it can get obstructed. There can be a vascular injury. You can injure the hepatic artery or hemoperitoneum, etc. Biliary injury is possible and stent can get dislodged. So that was about TIPS. TIPS alone is asked many a times in theory question as a 5-mark part of a 10-mark question. Okay, for 5 marks it is asked. So coming to the penultimate part of the presentation. So complications. So GI bleeding, of course. There is massive splenomegaly, hypersplenism causing pancytopenia, thrombocytopenia, etc. Ascites, hepatic encephalopathy, hepatopulmonary, portopulmonary, hepatorenal syndrome. So all this we have dealt already in chronic liver disease. Something similar to that. Okay, something similar to CLD only will have all this, because once the portal vein is blocked, no, all this can result. So some few points about portal biliopathy. That is, because of the portal cavernoma, what happens? This is the portal vein. So much of cavernoma is there. There is compression of bile ducts because of the varices. Okay. So, there's extrinsic compression of the bile ducts due to the varices around the common bile duct. This will cause ischemia, that will cause biliary structures resulting in biliopathy. So, the patients will have an obstructive kind of a jaundice and cholangitis. So, this is treated by stent placement or endoscopic sphincterotomy and rarely by surgery. Okay. So, with that we come to the end of this chapter discussion on portal hypertension. I hope that was very helpful for all of you. Thank you.